Good evening, everyone, and welcome to our sixth installment of A Journey Through the Psychedelic Revival, a series sponsored by Penn Nursing. Thank you all for joining us today. I'm Toni Villarreal, and I'm the Margaret Bond Simon Dean of the School of Nursing here at Penn. This series certainly has been a journey. So far, we've discussed the historical roots of psychedelics and their emergence into Western medicine, what is involved in preparation for therapy, and what happens during a psychedelic therapy session. We've talked about psychedelic neuroscience and pharmacology, the research being conducted, clinical application, and ways to get involved, as well as the future of psychedelics. I often say that nurses are better positioned than almost anyone to recognize opportunities for innovation in health and healthcare. Our proximity to patients, our holistic perspective, and our natural inclination to solve problems in inventive ways gives us an edge. However, we also know that despite our best intentions, access and equity issues continue to be of concern in health and healthcare. Penn Nursing is committed to addressing structural inequities to enhance health and quality of life for all. And tonight, our conversation around the use of psychedelics takes us into that very subject. What avenues are being taken to address issues of access and equity in a proactive manner? Our panelists tonight are experts in the field, and I look forward to what they have to say on the subject and to the discussion that they're going to have. Before we start the panel, however, as we've done, there are two items of housekeeping. First, over the last several events in the series, we always seem to have a small handful of people who experience technical issues, and for that we apologize. So here's what we've learned, and again, things that might be helpful. For poor connections, try closing any extra browser window programs running on your computer. Switch to Google Chrome, which we find works best with the platform we use for these webinars. If you're unable to log on to this for any of our sessions, the fastest way to overcome the issue is to re-register for the event. You'll receive a new link to the event right away. And if you continue to experience technical issues, there's a link to the Blue Jeans tech support team located at the bottom of the event email. Contact them directly. And finally, if nothing else works, all sessions are being recorded, so if all else fails, you can view them at a later time. This brings us to the second housekeeping issue regarding continuing education credits. If you would like to receive continuing education credits for this event, we will post a link for this. We are going to send you an evaluation towards the end of the session through an email. So keep an eye out for that. The deadline for submission to receive credits is Saturday night, April 3rd at Eastern Standard Time. And then we will send a certificate to you via email by April 12th after the conclusion of the series. If you have any additional questions, please utilize the Q&A section. As always, now, before we get started with the panel, I invite you to watch a short video to humanize and personalize this type of therapy.
My name is Rachel Peterson. I'm a Master's of Divinity student at Harvard Divinity School and an environmentalist. Starting around age 12, I developed what we would call symptoms of major depression. Would just lay on my parents' floor, crying for days, and it seemed like my mind kind of just would stop the dance of the world with its stuckness. For many years, from ages 12 to 28 pretty much, I tried the standard treatment in our culture for depression. Many medications, mixes of medications, therapy, and some things helped me kind of function on a day-to-day level. And on the outside, often I had quite a bit of success in my career, but I was often just barely surviving, and nothing really touched this kind of deeper substrate of despair that I experienced. I was worthless, I was constantly worthless. I could just never register a sense of being loved or held, even though I was, that never connected for me. And then another way in which my depression operated is that I was constantly obsessed with the suffering of the world, constantly obsessed. And so, I think it was just very difficult for me to connect with any sense of hope or possibility or love because of the two ways that was kind of operating in my adolescent life. And growing increasingly desperate in my 20s for relief, I didn't really hesitate when a friend of mine, who was a medical student at Johns Hopkins, told me about the clinical trial to treat major depression using psychedelics. I'd never done psychedelic drugs. I was way too afraid. So I didn't know what to expect when I enrolled in that clinical trial in 2018. The treatment was 2 high doses of psilocybin. I think the most memorable thing for me from the first experience I had was really feeling like becoming one with the natural world. But then I remember the music changed and it became quite ominous, and I had a thought of, oh, well, all of this is being destroyed, we're losing this. And so I went through this incredibly intense, I just remember like sobbing with like an agony unknown in my waking life about kind of grieving all of this loss. And I remember like asking out loud, like to nothing in particular, but just asking like, what is there after this, right? Like, what is there? What do we even do? What do we do with all this loss and pain? And that's when my kind of whole experience broke open. I had never experienced such a sense of being held by a kind of ineffable beyond in my life. And I remember just feeling like I just had permission to play and to experience joy. I remember after that first experience, someone in the trial kind of casually was like, "Do you still consider yourself an atheist?" And I was like, oh, why can I not answer? Why for the first time in my life am I like reaching for a word like God? Knowing that I was held by this beyond helped me hold my own suffering in a different way and hold other people's suffering in a different way. And so it was very humbling to, in my second experience, be confronted with something that was totally different from the first one. I had a very interesting experience of encountering people who had harmed people I love and people who had harmed me, and feeling this incredible amount of compassion for all of them. And I remember being a little angry because I was like, I don't want to feel compassion for these people who have hurt me or who have hurt people I loved. But I really just had this deep felt sense that at our core, we're all whole and unbroken. And the only way that we harm others is when we forget that wholeness and that unbrokenness. And I think for me, psychedelics have been an invitation to become who I am. My life has so much more richness now and so much more meaning. And I really feel like I've been changing the way I live. Yeah, some sadness came back, but it's not that sadness or that doubt or that inadequacy is smaller. It's that the space around it is so much bigger. In all of that, I can find a kind of divine okayness that I never sensed before. And what's interesting is people use the language of you need to integrate the experience into your life. But I kind of believe, no, you have to integrate your life into the experience. Like the experience showed you something true. So how do you live your life in accordance with that? What I say is that those experiences pointed me towards the trailhead of myself. And I had to walk to that trailhead and decide to walk down it. Through my psychedelic experiences and my spiritual practice, I've come to really believe in the power of nevertheless, right? So like, yeah, the world looks really dire right now. Nevertheless, it's worth living life. Every small moment you wake up and you smile at someone or you say something that matters to them, that's what a life is. And so I think the trial, rather than being kind of a very simple silver bullet, has given me an invitation to inhabit a fullness of my humanity that I didn't have before. It was pretty life-changing.
We're so grateful to Rachel for sharing her story and her journey. Thank you. And now I'd like to welcome back Stephen Apron, who will moderate tonight's panel. Mr. Apron is an award-winning filmmaker and social entrepreneur. For those regularly tuning in, you've already watched some of Stephen's work via the Stories of Healing short films, which accompany each session. Mr. Apron is the director and producer of Disturbing the Peace, which received the first Roger Ebert Humanitarian Award. He is the executive producer of Fantastic Fungi and the founder and former executive director of the Jacob Burns Film Center, a nonprofit film and education center located in Pleasantville, New York. He is also the author of The Age of the Image, Redefining Literacy in a World of Screens. Mr. Apron co-founded Reconsider, a nonprofit organization that supports the emergence of transformational medicines to address the underlying causes of today's most critical societal and mental health challenges by recognizing their transformational journey. Sorry. So with that, I would just like to welcome then Mr. Apron to serve as our moderator for this next session. And again, thank you again so much for being with us, Stephen.
Thank you, Dean Verwell, and thanks to the whole UPenn team for putting together an amazing learning series. This has been absolutely fantastic, and you all deserve enormous gratitude and appreciation from all of us for your vision and your leadership in being the first nursing program to recognize the importance of this reemerging field of psychedelics. And it's been a real pleasure to be collaborating with UPenn, and I also want to thank the Reconsider team, especially Sean Gallagher, for their exceptional work in creating the Stories of Transformation films that have opened each evening. For access to the films, which will also be available on the UPenn site, as well as to stay in touch on all things going on at Reconsider, you can always email us at community@reconsider.org. And tonight, I especially want to thank Rachel for her courage and vulnerability in sharing her story. Dr. Verwell mentioned the topic of tonight's event, and as last session, we're thrilled to bring together a panel, and we have a great one for you. One thing you'll notice that's different about tonight is that unfortunately the chat function isn't operational. It's been wonderful to see people reaching out from all parts of the country, and I want you to know we're really glad you're with us. The good news is that the Q&A function is working and that you can share your questions with us there. We hope to get as many as we can while recognizing that we have 4 panelists and a lot of ground to cover. Speaking of that, I'll keep my introductions very brief. Dr. Joseph McCowan is a clinical psychologist and psychotherapist. He works with the California Center for Psychedelic Therapy, where he provides ketamine-assisted psychotherapy, as well as psychedelic integration therapy. He's also a co-therapist in the MAPS Phase 3 clinical trials of MDMA-assisted psychotherapy for PTSD, and an alumni of MAPS MDMA therapy training for communities of color. Joseph is deeply passionate about furthering education and awareness of the healing benefits of psychedelics for communities of color, and in working to improve mental health outcomes for historically underserved communities. Welcome, Joseph. Dr. Hannah Mclean. Thank you. Dr. Hannah Mclean is a physician, psychotherapist, and entrepreneur. She's the founder and clinical director of the Sound Mind Center, a psychedelic therapy center in West Philadelphia. At Sound Mind, Hannah focuses on providing accessible and inclusive psychedelic care on education training therapists and clinicians, and with research including ketamine and MDMA with plans to add psilocybin. Dr. Mclean's expertise lies in the areas of psychedelic ethics, cognitive diversity, and contemplative studies. Welcome, Dr. Mclean. Leah Mix, our third panelist, is a licensed marriage and family therapist. She's the founder and CEO of Anthea Health, an insurance company dedicated to consciousness-focused healthcare. Leah has over 20 years of diverse experience in the behavioral health field, including 15 in managed care organizations. She's an adjunct faculty member for the Certification in Psychedelic Therapy and Research program at CIIS. She is very much a systems thinker who has helped achieve insurance coverage for new behavioral health treatments and implemented industry-leading clinical programs at a national scale reaching millions of people. Welcome, Leah. And finally, Rick Doblin. Rick is the founder and executive director of the Multidisciplinary Association for Psychedelic Studies, the organization we know as MAPS. He received his doctorate in public policy from Harvard's Kennedy School of Government, where he wrote his dissertation on the regulation of the medical uses of psychedelics and marijuana, and his master's thesis on a survey of oncologists about smoking marijuana versus the oral THC pill in nausea control for cancer patients. His professional goal has been stated to help develop legal context for the beneficial use of psychedelics, primarily as prescription medicines, but also for personal growth for otherwise healthy people. And he hopes to eventually one day grow up and become a legally licensed psychedelic therapist. Welcome to all of you. And Joseph, I'd really like to start with you tonight. This is a conversation about access. We know that access means different things to different people. It's sort of like reciprocity. Rather than listening to what indigenous people consider reciprocity to be, we often want to provide them dollars rather than listening to what they really want from us as a sign of respect. In regards to access, this can be true as well. There can be a notion of bringing these medicines to certain communities in an almost, as you've said, missionary way, rather than starting by listening. And that's where we'd like to start tonight. We know this can actually be re-traumatizing, in fact, and we know that access is more than just about dollars. I'd like to ask you if you can help set the stage for this conversation for all of us around how we can define and think about access. And first, you need to unmute. Oh.
Got it. Thanks. Thank you, Stephen. Happy to start things off, and yeah, very grateful for this space and all the other panelists that are here. You know, as Rachel shared in our video on inhabiting, you know, through her psychedelic experiences, inhabiting the fullness of her humanity and the shifts and intentions that came along with that. You know, often I feel, you know, the psychedelic ethos is like interconnectedness and interdependence and wholeness and unity and really embracing the complexity in all of us and in everything and unifying us, right? And this is a collective effort, right? And it involves all of us in an ongoing way, in an intentional way. And really, you know, the psychedelic renaissance and health equity and social justice are not separate, but intertwined. And, you know, at any level in any of the work that we do, it's really necessary that we're weaving in health equity into our work at any level of that we're working at in this field. And, you know, really this begins with being intentional about centering the needs of those who are the most vulnerable and the most impacted, and those who haven't been accessing this care and these medicines. And these are often folks who need healing the most, as well as those who have been, you know, previously and historically, like both, well, mostly intentionally over the centuries, disconnected from these medicines, following a period of, you know, really pure connection with them. You know, we all know the history of colonization that really impacted and separated indigenous and native cultures and communities from these medicines, and that remains today for many. And it has been those who, you know, I guess, or the descendants of those who separated those communities from those traditions and those practices and those medicines that are now embracing them today. And, you know, as you mentioned, Stephen, you know, the importance that really this isn't missionary work. It's not the process of just bringing these medicines to communities, but really connecting with communities and individuals, listening to and learning from them around what the specific challenges they're facing with regards, or the barriers that they have related to accessing these treatments and these medicines, and recognizing that they're the experts on their experience and the reasons historically as well as currently why that access isn't there. So really, you know, it's kind of embracing cultural humility and decentering ourselves and centering those that we're hoping to connect with and serve, and really allowing their expertise and wisdom to flow, and really honoring, the fear, the avoidance, the hesitation, because, and I imagine we'll speak to a lot of this in a bit, but there are a number of reasons why folks are hesitant to engage with, therapy or psychedelics or research. Often these are all carry a heavy stigma in certain communities, and for good reason. I can share more, but I'll stop there for now to allow others to chime in.
I really appreciate that, Joseph. And when you talk about, reason for mistrust, it's also, there is a legacy of harm that's been done to certain communities in medicine. So recognizing that there are different barriers as well in regards to experiences in the past.
Right.
And Hannah, you're right there in the UPenn neighborhood. You're around the corner. And you've thought a lot about access, both for those receiving care as well as for those providing care. And you also thought a lot about ethics. And I know your commitment to providing accessible and inclusive psychedelic care. How do you relate to what Joseph is suggesting, and how do you approach access in your work, both in regards to delivery of care and in regards to training?
Yeah, thanks for that question. So Joseph and I have actually been teaching together for a couple of years now in the therapist training program. So we've talked a lot about these topics. Voice texted, it's like a lot of, the complexity of like, what does access mean? And like, where are we starting from? And I think there's this idea that like you get someone in the office and that's where access starts, but it feels like there's so many other things. There's this whole ecosystem developing that it's not just like when someone comes into the office, make sure that you're having culturally sensitive care for whoever they are, but also like, is the therapist that they're working with, do they have the option of that person sharing an identity with them? So if they're BIPOC, if they're trans, if they're neurodiverse, do they have the option of finding a therapist that does share that identity? And as Jennifer Jones once said to me, she's a therapist and advisor for SendMind and works with MAPS. She was talking about, you don't necessarily have to have someone that shares that identity, but there's a problem if you don't have that option. Someone can be trans and decide like, that's not important for me to have a trans therapist, but they should have that option. So at SoundMind, we're really focusing on trying to train a diverse range of therapists so that when someone comes into the office, they actually have that option. And also just like the really earlier education around like just thinking about how someone would end up at a MDMA trial. There's so many steps they have to go through to get there. So they would have to know that they have a diagnosis that has a name, and then they have to probably go to Google and search that diagnosis and see like what are alternative methods, and then they'd find a trial, and then they'd enroll in the trial, and then they'd end up in the office. So Joseph and Rick and I actually a few years ago put together an animation around like what is PTSD and like what is MDMA and how can that help, just like really basic, like what are the symptoms. So I think that having this concept of like access is a bigger question than just like how many patients are treated that are marginalized, but like how do people find their way into the clinic? What are their options once they get there? What is the education for clinics to be culturally sensitive? So we have various initiatives around like educating clinics around cultural sensitivity. So Joseph and I have worked on that a little bit, and Robin Devine. And I have talked about just how to spread some of her work with educating clinics in the psychedelic space to be more sensitive to BIPOC patients. We're working on also like a guide for trans folks and how clinics can be sensitive to them. I identify as dyslexic, and just thinking about like how can we make sure that things are accessible, that people, that might not go to sites and that are like heavy on wording, like how do we find those people, and how do we make sure that they're getting information in various forms, whether it's through audio or video, or even when we're putting together like preparation materials, are we thinking about all the different ways that someone might receive information? So it's not just written, but it's also spoken, it's also video. So I think there's just broadening the idea of what access is, and also the idea of reciprocity. I think I see there's like certain concepts that keep getting repeated over and over, or like I hear about them, like this idea of indigenous reciprocity, like let's just like take some of our profit and send it to Peru, or whatever the idea is. And I think in a lot of ways it's about making like personal relationships with people, and then asking them like, what do you think? If someone has an identity and you're like, what do you think? Can you talk to your friends and see what you think would be the best use if we did have extra funds? So someone that that we're working with at SoundMind is Belinda Ariacho, who has this idea that she identifies as Native American, and she has this idea that maybe we could use ketamine-assisted psychotherapy to help heal some of the PTSD in Native American communities. And it's like, that's not something I would have thought of, like bringing something that's like so much in the medical model into that community, but that's what she is driven to do. And so I am driven to help her, see that through, and really just listening, not in like I think it's like one-on-one listening and forming relationships, and really figuring out like, how can any additional, whether it's profit or any additional resources, how can they go towards actually spreading and creating a ripple effect?
Yes, listening to listen instead of listening to speak.
Exactly.
And I love what you said about really this notion that that access is also about a freedom of choice, whatever that choice you make is. I can't help but think of when you spoke about reciprocity, reciprocity for the Kogis in Colombia, might just be take care of the planet that we all share.
Or like pray, or give back to the plant by like praying to the plant that you're using, like right. Just, it might not be what you think of as reciprocity. Yeah. Exactly.
And you brought up a lot of the challenges in these trials and historically, and that really leads me to turn to you, Rick. MAPS will very soon likely be in a position to offer MDMA as a treatment for PTSD. And I know that you're engaged in research around other indications as well. So we're going to get to the question of how patients will access care a bit later tonight, but I want to first start with research and education or training. And I know that you personally have been deeply committed to this work for over 30 years in this mission, and that the MAPS trials began close to 20 years ago, and that your first trials were very limited in terms of numbers. The N was very small, and also limited in terms of the communities that participated. Can you speak to how this has evolved? Hannah began to mention that. And also, we know there's a bottleneck that's coming that's going to be critical to solve in the ability to ensure access. And that's the sheer number of trained facilitators. Alicia from Philadelphia at our last session asked whether there's going to be focus on training therapists who represent marginalized communities. You mentioned the queer, BIPOC, and immigrant communities, among others, to match the cultural and social needs of these populations. I want to ask you what MAPS has been doing around access, especially in regards to research, training, and facilitation.
All right. Well, thank you very much for organizing this and moderating. So I would say I had thought initially, mistakenly, that access in terms of the full range of people that were traumatized with PTSD in our culture volunteering for our studies, I thought that would happen automatically. And in particular, when we started working with veterans, I know that the military is 40% of color, that it's more integrated than most parts of our society, and that there's a very close understanding about people helping each other and being willing to sacrifice their lives for each other and working together. So I had just assumed that when we did our study with veterans, firefighters, and police officers, that there would be a substantial number of veterans of color that would volunteer for the study. And we had none. And so that's where I knew about the Tuskegee experiment. I knew about the, distrust that a lot of minority people had about the medical establishment, but I thought that was in the past. And somehow or other, that was a long time ago. We all think of that as a terrible scandal that's universally condemned, what the Tuskegee experiment did. And so it was a big eye-opener for me to realize that it wasn't in the past for a lot of people, and that this suspicion of the medical establishment and this more further idea of being vulnerable. When you take these substances in a therapeutic setting, you have to become very vulnerable, and how that was something that people weren't comfortable doing. So once it was clear that it wasn't happening on its own, that access was really widespread, what we realized next was that we needed to train therapists from these marginalized communities, African Americans and Asians and others, sexual orientation, all of this, that we needed to affirmatively go out and try to train therapists so that patients would have therapists that looked like them or were sexual orientation like them. And so what we've been able to do over the last couple of years is to give over about $1 million worth of scholarships to about 230 therapists of color and from marginalized communities, including a few Native Americans and stuff. But it took actively doing that, and I'll just say it was, again, this blind spot that I had that somehow it would automatically take care of itself. I think this broader question about access, we talk a lot, and Leah will talk about this soon, but, this idea of getting insurance coverage, that's a key aspect of access. But in America, we have, a quarter to a third of people are uninsured or underinsured. And they're not likely to get, even if we do get insurance coverage, there's going to be a substantial number of people that are not able to afford the treatment. The other part about this in terms of our patient access fund is that it's really easy for pharmaceutical companies, when you see their ads on TV and they say, if you can't afford the drug, contact us and we'll give it to you potentially free. The drugs themselves are very minimal cost to produce. I mean, there are some drugs that are more biologicals, some that may be more expensive, but in general, these drugs are extremely inexpensive to produce. It's the research over decades sometimes, or a long time, that's very expensive, and then they amortize all the costs of the failures into the few successes. But in general, for pharma companies to provide free medicines to people is easy. But that's because the medicine is the medicine. In us, it's psychotherapy is the treatment that the psychedelics make more effective. So we can give people free MDMA, but that doesn't do them any good if they can't afford the therapy. So that raises this whole question about how do we actually have a successful patient access fund that provides the drug and the therapy to people. Now, the therapy can cost $10,000. The drug can cost us $150 or whatever. So, how do we set the pricing? When we think about the price for our drug, there's a reason to have a higher price so that we make more money, so that then we can afford to give patient access funds where we pay for both the drug and the therapy. And then, how much of that, the higher price will be paid for by insurance companies and the other. But I'd like to raise a bigger issue here, which is drug policy reform. And so access, not just as a medicine, but access as a fundamental human right to explore your consciousness. And so our long-term goal is this idea of mass mental health. The two-pronged strategy, one is drug development, the other is drug policy reform. So what we would really like to do is to provide access to people to purchase the drug in some sort of licensed legalization or other scheme where they can buy the drug and then they can self-medicate or use it for other purposes that are not treating medical conditions. But in order for that to really work well, what we need is honest drug education in schools. We need peer support. We need to train people in how to help your friends and yourself, with difficult experiences. We need, pure drugs and drug checking. And we also need treatment on demand so that if people do get into problems with these drugs, then they can seek support for that. So I do think that a part of the access question is not just about making this into a medicine, but it's making it legally available for people to do work on their own. Also, there's so many different uses of psychedelics that are not medicalized. So, for example, psychedelics for spirituality, a lack of a mystical experience is not something the FDA is ever going to approve. I've been told by some of our FDA consultants really in the last few days that MDMA for couples therapy is one of the best uses of MDMA. But one of our advisors was saying, don't do that research until after the FDA has approved the drug, because they might be worried that when you start talking about MDMA for general health and wellness, not for treatment of diseases, that they'll think that you're sort of trying to, get it used for things that they're not comfortable doing. So there's challenges there.
I'm really glad that you went there in regard to drug policy reform, Rick, and I want to come back to that a little bit later because I think it's a really important question around access. But you also touched on the economics.
Yeah.
And with that, I want to turn to you, Leah, because MDMA and psilocybin are in the process of being approved by the FDA in combination with, as Rick mentioned, a therapeutic process. And while access is not just about economics, as we've said, economics are certainly going to come into play. The model that seems to be coming through involves 2 clinicians for the duration of the session, as well as preparation and integration sessions. And in short, it's going to be expensive. It's going to be expensive to deliver it in its current model. And that's where payers and insurance companies come in. Leah, you are one of the most thoughtful people I know in this field. You've been focused not on the glamour of an emerging transformational medicine, but rather on the nuts and the bolts of how people are actually going to be able to access and pay for these therapies. And Thea has been your response to this question. And you've recently announced your first company signing up to provide psychedelic care to its employees. Can you tell us how you see this process emerging? First, you need to unmute.
Thank you, Stephen. So enjoying this conversation. That's a really big question. Sticking with the topic of access and my little slice of the pie, which is medicalization, I'm typically, as you said, I'm going to be coming at this from a structural mindset. How do we actually get the nuts and bolts to work so that we can create access in a way that is respectful for the communities that need it, for the people that need it? And there's this sweet spot, and I'll get to it, this tension of how do we create the structures in a way that are loose enough that we can still learn, because we have so much still to learn about what is psychedelic healthcare. What does access look like? What does access look like for communities of color or any kind of unique human being, right? So there's a way of going about it, and I'll try to speak more in specifics. There's a way of going about it where we can roll it out, but also kind of hold open the possibility that we will change it as we go. So I'll give a few examples. When we talk about the current existing model as a 2-person model, and I'm gonna back up and say, I hear that repeated often, that this is expensive, and I really want us to contextualize that when we say that, because in the broader system, this is extremely cost-effective care. It's a no-brainer when you actually do the math in terms of how it impacts overall costs to society, to employers, and so on. What we're talking about when we say that is it's too costly for most individual people or households. That's what we actually mean. So how are we going to make sure that people can have access to this in a way that's culturally appropriate? I don't think that we should be talking about access unless we're talking about culturally appropriate care, right? So the reason for that is that if psychedelic healthcare rolls out too quickly in a way that is just focused on a particular subset of the population, say wealthy white people, right? People who look like me, it starts to define what psychedelic healthcare is. And that's not right. We need the psychedelic tide to float all boats as much as possible. We need the learning to be happening in as many domains and many different communities of diversity at the same time as possible. So we're learning what needs to be reimbursed and what it needs to look like here and there and everywhere. And it doesn't get codified in a particular model. Now, what we have right now is what's in the research. And I think this two-person model is actually great. One of the reasons I think it's great is because it gives the opportunity for people from diverse backgrounds to be working with the patient. So let's say one of the practitioners did not need to be licensed, needed to be certified. Absolutely, you have the right oversight and all these types of things, but then it removes the barrier of having a full behavioral health license, and that's a barrier for a lot of people of lower socioeconomic status and people of color. So with this two-person model, we start to open up. If you can have a non-licensed person in the room, you start to open up. Now people have access to more culturally appropriate care, right? And the people that Rick was just talking about can look at possibly getting trained and going back into their communities and offering that care and learning. So that's one example of structurally, from a training perspective, how we think about access. We want there to be more people who are able to be trained. And if there's an appropriate kind of certification, like with a nationally accredited certification board, those individuals can actually be reimbursed. So now you have people who are carrying these medicines from different cultural backgrounds, different spiritual lineages, working alongside people who are licensed clinicians working for a more Western, medical model, psychological model, working together. You get cross-pollination of these wisdom lineages, and everyone's getting reimbursed, right? That is one vision of what could possibly be. There's a whole other conversation about diagnoses and how it gets defined, what types of diagnoses the medicines are covered for. But I've been talking a while, so I'll stop there.
No, this is a great panel because everybody is leading into sort of the next conversation that has to be had. And you mentioned diagnoses, and I look to you, Joseph and Hannah. You're both clinicians, and you're both very interested in cultural diversity. And we're still talking right now about a medical model, and it's a model that's based on diagnoses. So doesn't the question of access have to begin with the nature of how we diagnose? In other words, aren't we using a limited conceptualization of what trauma might be? We often think of veterans or those who are victims of sexual abuse or domestic violence as suffering from PTSD. But what about racial trauma? What about the trauma of others? And how do we reshape this conversation to impact access?
Definitely. Very important question. Thank you for what you shared, Leah, and what you also shared, Rick. Leah, you were mentioning culturally appropriate care and, how important that is. But, we don't have culturally appropriate diagnoses, right? And that's going to be necessary toward culturally appropriate care. And, there's so much work to be done. There's the need for intentional inclusion of more diverse voices and individuals in the development of research and protocols, but as well as looking into racial trauma, intergenerational trauma, effective methods of supporting folks with these challenges. We need therapists that can relate, right? And so that clients and participants are able to feel like they can relate to the therapy process, or a mental health approach that like speaks to them or meets their needs. And a lot of the work that we do in the Mdma therapy training program, and Rick was kind of referring to this. I guess I'll start by sharing. When I was trained, I was part of the first wave of, MAPS was intentional around developing a training for therapists of color in 2019, which really, not only was it a safe space for us to have these conversations and develop intentions towards, supporting folks from underserved communities and with these therapies and with these medicines, through education and outreach, but also, really looking at racial trauma, intergenerational trauma, what people are carrying, what types of support that they might need. This was really like career shifting for me. Never in a psychedelic space had those conversations been like front and center, and and really like that, really enlivened in me and many others. Like, that there's so much work to do, and it's long-term work, and we are all kind of connected and going to be doing it in the long term. But again, there's a lot of work to be done. But as Rick was sharing, there's was unsure of like whether things were just in the past or whether they were currently present with folks as well. And James Baldwin says, like, history is not the past, it is the present. We carry our history with us. And many of our historic wounds do live on with us. And especially for folks who have been oppressed and traumatized historically, but are also currently experiencing that as well. It's like it never really stopped for many in certain communities. So, part of equipping ourselves and equipping therapists and meeting people where they are and really expanding our conceptualization of trauma includes like developing that historical consciousness. It's not always what we see when someone is presenting or coming into a space with us, but it's what we can know that one might be carrying, and making space for like their sharing and that narrative to unfold, which sometimes doesn't unfold immediately, right? There's often that development of safety that needs to be made, and trust in the therapy space. So really, like, culturally appropriate care is so many things that really it's more about being than really what we're doing, like making space for folks to feel safe and to share themselves, and to really, as therapists, for us to learn about them and their experiences. And then the opportunities for healing, like racial trauma and intergenerational trauma, are so many, right? Like, Rick mentioned this as well, like folks who have a history of like not being able to be vulnerable because that would like lead to harm, essentially, carry that as well. So just entering a space and opening is something very different for different groups of people.
And it also speaks to the question of set and setting, and that needs to be responsive as well. For instance, groups versus individual treatment, may make sense in certain situations. Even as you talk about setting, the choices of music and all of the things that go into creating the safe container and the experience for the participant.
Right. Right, but it can be so healing for one to enter the space and let that guard down. But it makes sense that guard is up, right? And
absolutely.
it makes sense that there isn't that ease of vulnerability.
Yeah.
And prioritizing one's healing might be a new pattern. Could be the first in a long line of ancestors, and who hasn't just pushed through their trauma, right? And so, yeah, like just having a psychedelic experience for BIPOC sometimes is alone is healing intergenerational trauma, right? Just entering therapy often alone is like undoing some of the many wounds of one's past. And and then disconnection from psychedelics is also part of the history of harms. Therefore, like even reconnecting with our ancestral roots with psychedelics is sometimes even, a way to reconnect with who we are and, find ourselves and more fully become who we are. There's a lot of work to be done in this area, and so many different ways that we can support therapists in working with folks of diverse backgrounds.
Thank you for that, Joseph. And I know you mentioned the other day when we were speaking a study that's going on at Emory University, looking at the attitudes of psychedelics around racial trauma. And so there is, work that's being done in that area. But I also think that, diversity is not just about ethnicity or what community you come from. One of our participants, Giovanna from San Francisco, in the last session, she observed that clinical trials with psychedelics have largely excluded individuals who experience hallucinations, such as people with bipolar disorder or schizophrenia. And Hannah, your work in particular has also focused on cognitive diversity. What do we need to overcome to reach those populations, including those just with other comorbidities, recognizing that the trials to date have been largely around a very specific indication?
Yeah, I think, this question comes up a lot. And thanks for everyone for your input about these questions, and Joseph, your answer to, how we can be limited as clinicians sometimes. But I think that people often see trials and they think like this is the only thing we're looking at. So we had one of our last trainings, someone said, they excluded people who have bipolar. Like why is that the case? And so in trials we have to think about, we're trying to make something that's predictable and like a group that isn't going to be like the numbers are all over the place because we picked like clinical presentations that are all over the place, but that doesn't mean that those populations are not ever going to be studied. So I think that there will be, as we go into the future, there will be certain clinics and physicians and trials that focus on these various populations. So like, for instance, with ketamine-assisted psychotherapy, some clinics don't treat people with bipolar because there's a possibility you can bump someone into mania. We will, but you need like a little bit more time to make sure that like you need to make sure your patient is going to report to you if they start bumping into, they're not sleeping or, so it requires a little bit more trust and just like relationship building to make sure that you will be in the loop if something goes on. And I think the same thing with folks with schizophrenia or other things. It's like, I think there will be doctors that really specialize in that area to see like, well, this person maybe it's not appropriate for, because psychedelics aren't appropriate for everyone. But there is a certain subpopulation that it is appropriate for, or this population, we're going to like be really careful and see and not do too high of dosing and then follow up. So I think it's really about, we get a first approval and then we go and look at all these other indications and different permutations of, how something might look and what might be appropriate. So I think just because a trial says like this person's excluded, if like you're a person that has that exclusion criteria, that doesn't mean you can never get that therapy. It just means in this particular trial, you're like, this is not part of the group that's being studied.
Yeah, no, that's very helpful. That's very helpful. And, Rick, you mentioned couples work with MDMA. There's so many other indications in addition to PTSD, which is the primary indication that's going through the FDA process. And we know that PTSD alone, there's enormous demand, right? The statistics say that there's, more than 8 million people on a given day, just in this country alone suffering from PTSD. Those numbers are before COVID and everything else going on in the world. And we've talked about how access is going to be a function of trained facilitators, with estimates of more than 100,000 trained therapists and facilitators needed in the next decade. I want to ask you about a recent podcast that told the story of a MAPS trial participant and her facilitator who ultimately started a sexual relationship with her. And it is sadly not the first case in which health professionals have violated trust and hurt patients, well outside of just the psychedelic field. And it's not likely that it'll be the last. We also know how much good this work has done for so many in the trials and frankly in the underground for so many years. It's also clear that this therapy introduces a unique level of vulnerability and sometimes loss of control. How do we make sure as access expands that safety is protected and not compromised in any way?
Well, I'd say first off, that's an impossible goal. Because of the large amount of therapists and psychiatrists that have initiated sexual relationships with patients having nothing to do with psychedelics. So I think we can try to minimize things, but this goal of trying to make it so it never happens, the goal should be to make it never happens. One case is one too many, but I think we need to be realistic about human nature. There's another big part of this which has to do with the way the FDA regulates medicines once they're approved, which means that the FDA does not regulate the practice of medicine. So they permit doctors to prescribe off-label. Sponsors can't knowingly sell off-label, but doctors can prescribe off-label. What I mean, how that relates to what we're talking about here, though, is that what we believe is that the therapists that work with PTSD patients all need training. And the training should be in the method that was used to make the drug into a medicine. So for MDMA-assisted therapy, we have our own treatment manual. We think people should learn that. For, let's say, psilocybin becomes a medicine for treatment of depression, the way that those psilocybin therapists were trained, the way the sessions were conducted, people that want to deliver psilocybin for depression should be trained in the method that was used to make it into a medicine. But once that happens, then they don't need to use that training, they don't need to stick to that method in how they deliver the treatment to the patients. They can innovate. We want people to innovate. I used to talk about MDMA-assisted therapy. Now I talk about MDMA-assisted therapies. So we have our own treatment method, but we're sponsoring studies to blend MDMA with prolonged exposure, with cognitive processing therapy, with cognitive behavioral conjoint therapy. We think that one of the best ways to try to minimize this kind of unethical sexual relationship is through a patient bill of rights, so that they understand, that this shouldn't happen. Here is where they can complain if that does happen. We already do have that in our training of therapists, that this is not appropriate. There's a large percentage of psychiatrists and therapists who lose their license. It's precisely because of engaging in these sorts of sexual relationships with patients. The essence of our method, the way that we understand it in terms of power dynamics, should itself be an antidote to some extent to this kind of work, in that we are healing patients, we are helping patients to heal themselves. That's the way that we're doing it. There's this idea that there's this inner healing intelligence. We support people to experience and express whatever's happening, but to heal themselves so that they don't need to be continually dependent on MDMA therapy. Once they've learned this process of how to take feelings that have previously been overwhelming to them, but how they can manage them, how they can process that kind of trauma initially under support, then they can do that when they're repeatedly exposed to additional traumas in their life, either from racial trauma, as Joseph was saying, which never really ends, or if it's single incident or complex trauma. We need to help people develop these tools to keep this process going on their own. And we do see that at the 12-month follow-up, people on average are better off than at the 2-month follow-up. So there is this self-healing process. So yeah. I would say that, we have had over 360 patients that have been treated with MDMA. As far as we know, there's only one case where a therapist had a sexual relationship with a patient. So, there may be others that we're not aware of, but nobody has brought that to light.
Yeah.
So I think that we're doing pretty well, but, we need to keep vigilant about that. And we need to, again, the core element of this kind of power dynamics, a lot of times in shamanism or in other things, or even in psychoanalysis, it's the psychoanalyst that does the interpretation. And they then give this to the patient in a way, so that they are the healer. The source of the healing is outside the patient. We're trying to make it so that the source of the healing is inside the patient, and that they can do that on their own, and that will hopefully make them stronger when there is, pressure perhaps from therapists to, engage in a sexual relationship.
Yeah. We've talked in past sessions about the notion of the inner healer, and that's really what you're talking about. And a friend of mine recently shifted the way that I thought about this when he talked about how in their community they're referring to the person who is taking the medicine and going through the therapy as the practitioner, as opposed to the facilitator being the practitioner, with the notion being that it's putting the responsibility and the possibility on the person who's actually doing the work of accessing their own inner healer and working through their own traumas. And I thought that was really, really interesting way of looking at it.
Yeah, I'd never heard of that in that way, but I like that idea. Yeah, that we really want to empower the patient to heal themselves and to become the agent of their own healing going forward.
Can I chime in on that?
Please,
yeah.
Leah.
I have just a careful there. There's a slippery slope. So yes, like we want to say we know that these medicines are activating our innate healing wisdom, but the language that we're using right now, if someone is presenting for treatment, let's say, the person who is saying I am the practitioner, I am the clinician, does have responsibility for that person's safety. I just want to point out, when we start to say, oh, you're the practitioner, the responsibility is on you to keep yourself safe. I mean, just let's
appreciate that. No,
about that.
Yeah, I appreciate that. It's not an abdication of responsibility, and we need to be thoughtful about the way in which we structure that relationship, for sure.
May I add about? Thank you so much. I just this particular point about safety, I think, is so important, especially people who are listening, who are thinking about training and so on. There's a reason that working with these medicines is a clinical specialty. It is not the same as doing standard psychotherapy. There are things that can prepare one to be ready to train that are helpful. But as Alicia Danforth has said, like, when it comes to being trained, like, would you want to learn to scuba dive from someone who'd never scuba dived before, right? There's like that level of, this is something different. The transference and countertransference dynamics are very different, right? Amplified differently, experienced differently, just as one example. And so I just want to make the point that as we learn how to do this work well and how to train and how to be trained in this work, we at the same time need to evolve our ability to hold each other accountable. There are no regulatory bodies that exist today that really understand what this work is, how to regulate. How do you respond to a complaint? How would a medical board respond to a patient complaint with psychedelic therapy? They really don't know. And so that is another layer that is on us to look at, well, like, okay, we have a professional association that's coming into being. What's happening inside of that organization that will help us to know what to look for How do we bring forward concerns? What does supervision look like? And how are claims of wrongdoing addressed? These are all opportunities for healing. This is all the same thing. So I just wanted to mention that and point that out, and thanks for letting me jump in.
No, I think that's wonderful, and Leah, you've envisioned a whole system, I know, of certifications and standards and professional associations, and it is starting to come into being and will emerge over these next years, and is really an important element of it for sure.
I'm so sorry, Stephen. I just have to say, like, yes, there's that, and there are going to be some structures that people can work at, engage with.
Mm-hmm.
But this is also really about doing this at the community level, or however you define community, whether that be geographically or the people that you're connecting with, and just realizing we do need to evolve the ways that we're holding each other accountable, and learning about the process of delivering this care. And when there are ruptures, how do we address those, and how is that part of the healing process? That's not under the purview of any one organization. That's all of our work together.
For sure. No, thank you for that. A question came up in the last session around harm reduction, and I think it's very relevant to the conversation we're having. And I was just speaking with a good friend, Hanifa Noya Washington, earlier today. She's a founder of the Fireside Project, which is focused on providing support to people having psychedelic experiences. And this June, they will be launching an Affinity peer integration service, which in some ways speaks to what you're talking about, Leah, more directly toward the people who are using the psychedelics. They're going to have 40 trained folks in the BIPOC, transgender, and veteran communities. And people will be able to sign up for 45-minute integration sessions with someone from their own affinity group. They'll be able to have this freedom of choice that Hannah spoke about. And that's another way in which access is being impacted. And I also want to take a moment to recognize that access is also about global access.
Mm-hmm.
And Rick, you have initiatives in South Africa and in Armenia. And as part of Reconsider's Veterans Initiative this past year, we brought together veterans and their families. And my partner, Marcina Hale, was very clear that in bringing together military veterans, we should also include Peace Corps veterans. And we had a woman who spent 29 years in the Ukraine and was beginning an initiative to train Ukrainian therapists to treat PTSD with MDMA. She recently sold her house to move back to the Ukraine. And she did this 2 days before the Russian invasion began. We have been talking about access in the US, but it's clearly a global issue. And we will undoubtedly continue that conversation as we move forward. But if you can spend a few minutes and share with us how you're thinking about this globally.
Yeah, thank you so much for that. Yeah, so, we had 6 Ukrainian therapists that were about to start our therapist training program. Now they're involved in the war effort. Elizabeth Ames is the person that you were talking about. Yeah, was about to move to Ukraine. So we have 2 of our staff that have taken some time off and are in Poland with Ukrainian refugees right now. And what they've reported back to me is that there is not really a tradition of psychotherapy in Ukraine, the way that we think about it in the United States. And there are not that many psychotherapists or psychiatrists. And what they've been saying is that for these refugee populations, they think group therapy would be the way to go.
Mm-hmm.
But that we have to find other healers, other, we could say, facilitators, or who's going to lead these sessions, or who's going to manage them. There are not enough psychiatrists or psychotherapists. So similarly in Rwanda or in Somaliland or South Africa, we don't have enough psychotherapists in the United States. We're hoping to train 25,000 in the next decade, in this decade. But, you cited a number of 100,000. So we have to find other models to make this really accessible around the world. There need to be other people trained to do this treatment delivery than just limiting it to therapists or psychiatrists. And so how are we going to do that? And what other models are we going to find in group therapy? And then how do you manage those people that are having difficult experiences? Can you give them enough support? Or they get enough support from their peers? But when you've got a situation right now where there's 4 million refugees and there's an enormous amount of trauma, maybe it is okay to have it where on balance, most of the people are getting better, but there are some people that don't get the support that they need, and it, doesn't really help them. So I think we have to look at it in kind of a bigger perspective. And we need to really train a lot of local people then to continue it on afterwards. But they don't necessarily need to be therapists. It's going to be a really big challenge. It's easy for us, as I said before, to give away the MDMA. In the sense that the MDMA is not that expensive, but sort of training local people, even the challenge of doing it in different languages. How do we supervise them? How do we, have the videotapes? Do we even get things videotaped? How do we really do the supervision? How do we get the local people who are going to be helping others to have their own MDMA experiences so that they know what it is before they give it to others? I mean, there's an enormous amount. The burden of trauma around the world is just enormous.
Yeah.
And so I think we do need to find more models. I think those will lie in some sort of group therapy, but, not necessarily with therapists. And what, we want to do is to ideally, have MDMA manufactured in a lot of these countries. So that they can manufacture it themselves, that they don't have to get it from us. They can find other ways to do it. But there's no clear, quote, solution to the issue that you're raising. And I think we just have to start with, other models. There's another aspect to this, which is that in order to make MDMA into a medicine, we work with chronic PTSD, which means PTSD for 6 months or longer. Because there's a natural resilience. A lot of people will get better, and so you'd need large numbers of subjects if you really wanted to try to give it to people right after a trauma. But in places like Ukraine or elsewhere, one of the studies that I've realized would be really good to do was maybe we could give, let's say, 400 Ukrainian refugees at some sort of stable refugee center or something. And if we can somehow or other give each of them, or half of them an MDMA experience, one MDMA experience with support, the other half get whatever is available, but not MDMA. And then we look out as of a year or 2 years or so, did a smaller percentage of the people that got one MDMA session develop into full-fledged chronic PTSD than those that got something else. The idea I'm talking about here is MDMA as a prophylactic for shortly after the trauma, to try to make it so people can at least process it there. Maybe that doesn't harden into chronic PTSD. But we couldn't do that to make it into a medicine, again, because we'd need to have way too many people in the study. And, but doing one session in a refugee camp or something like that for a bunch of people could be a really good way to move forward. It would still be research. It is going to be a challenge. How do you keep track of these refugees when they're driven from their homes and who knows where they're going to go? But you want to track them, for years to come. But I think global access is going to be basically, I think, giving it away or having people make it in many, many countries of the world where they don't have a lot of resources, but they have a lot of trauma. And so to the extent that we talk about making money from the sale of MDMA, it would be US, Europe, Japan. Those would be the main places. The rest of the world, we could consider giving it away for free or helping people manufacture it themselves. We just published in a scientific journal our synthesis for MDMA for commercial quantities. We're not trying to, monopolize our production process. We're trying to make that so that that's in the public domain as well.
Another form of access.
Yeah.
Yeah. And as you were talking, there are, as we've been talking all night, there are many forms of trauma. And I think one of the things that you touched on really, Joseph, at the beginning of this was this question of trust, and I could also imagine a skepticism of, you know, the idea of using these medicines to make it okay to be dealing with the trauma that's underlying it and not changing the systems is at worst, at least a missed opportunity, and at worst much more serious than that. And you know, I think of my partner Marcino, who often says, you know, how long are we going to diagnose a fish that's swimming in toxic water? And recognizing that these systems that are creating trauma and the environmental issues that we've created out of it, you know, there can be depression and anxiety could be an appropriate response to the world that we're creating. And this also speaks, Rick, to your notion that these medicines are not only about treating trauma, but also about wellness, and connection and spiritual connection and all of that. A question that's come up from the people who are participating tonight, they're asking to go back to this question of the bottleneck of training and where training is going to be accessible, and especially in terms of equity and representation. You know, what are organizations doing to ensure, both higher educational institutions and other organizations doing to promote access for those who want to become therapists? And a specific question of whether there are any initiatives to include underrepresented communities in that training system outside of the Therapists of Color program that you have going, Rick. Does anybody know about other ones?
Yeah, well, I'll just say very quickly, just that Bob Parsons, who was a Vietnam vet who had PTSD, started GoDaddy, billionaire. He went to the University of Baltimore, where after he got back from Vietnam, that gave him his start. So he's been very supportive of the University of Baltimore. They do have a counseling program, and they have a lot of people there that are of color that are going to that program. So we have talked about trying to embed our training program inside their counseling program as a way to get more therapists from marginalized communities trained. So we want to embed the training eventually in schools of psychiatry, schools of psychotherapy, other training organizations as widely as possible. And then people can develop, culturally specific, culturally sensitive ways to do this.
Yeah,
I think we just have to really move the training as far as we can into traditional training so that many, many more people can get trained that way, not just through ours, but through schools of psychiatry and psychotherapy and counseling schools.
That's great. And I want to mention to everybody who's listening in that UPenn has created a whole resource site. If you go to the site of this event, and you'll be able to access resources, including Karen Cooper had a whole list of training programs. And so there's a wealth of information that you could go back to. Rick, you talked about drug policy reform, and I want to bring this back to you, Joseph. I want to take us in a different direction. We know that there is this emerging decriminalization, legalization movement happening in the country. In fact, we may be seeing the end of prohibition in some way and the war on drugs. And this alone can help address the question of access, and it perhaps raises other challenges. But we know that there have been vast disparities, not only in regards to access of these medicines, but in treatment of different communities in regards to the laws that were enacted to schedule these substances. I know we're here talking about a medical community, but I want to ask, how do you see decriminalization and legalization through the lens of access and also of efficacy?
Yeah, so just to hear the question correctly, you're asking how I see decriminalization through the lens of access and equity?
Really, how do you see access and efficacy through the lens of decriminalization and legalization?
I see. Okay. Well, I mean, if we're just considering the war on drugs, right? Like, that's part of the history of harms and leaves a legacy, and is going to continue to impact folks in some communities more than others, even when decriminalization, I guess, gains steam and is, I guess, once decriminalization is fully realized, which hopefully is sooner rather than later in this country, there still may be some like inherited challenges for folks who might have been more impacted by mass incarceration in their family than others, right? Just like the narratives around certain substances or the mythology that kind of comes with that, often through stories that folks share in their communities toward distancing from these substances toward safety, right? It's like so that the younger generation doesn't end up imprisoned, right? So there's a lot of like mythology that is going to need to be debunked, as well as experiences to be had for folks who never had the experiences. But that can really pick up momentum with the decriminalization process, as well as as Rick was mentioning, like connecting with like the University of Baltimore, for example, represents like an institution that is really tuned into their community, right? And like the folks that they're working with. And as decrim initiatives like show up in different cities around the country, like DC, for example, which has decriminalized for the most part, like plant medicines, and is a largely African American community, like connecting with like the Howard universities of historically Black colleges, and like what is their messaging, or how are they connecting with the community around not just training, but also education, awareness, just gauging folks' attitudes and experiences with psychedelics, and even potentially supporting new therapists coming into the space or having studies themselves. Because like as decrim like sweeps the country, hopefully, each locale is different, and those that are working in that region or that locale still need to be equipped to work with the folks in that community. And so still is like access is, it's important to consider making the treatment and the education accessible to the population in that region, as well as getting input and feedback from that community. Really having researchers that are equipped to do that through like community-based participatory research, and any sort of research that really involves community input and collaboration, versus what we were discussing earlier, like the missionary work of here are decriminalized plant medicines, and they're decriminalized, so you should feel safe with them. No, it's going to be much different than that. There's going to be a lot of variation cross-culturally and cross-regionally, and to just show up like holding that complexity as therapists and researchers.
That's beautiful, and I think that when we mention missionary, I don't mean that as a pejorative to religious institutions, but because there are multiple channels here. We're not just talking about the medicalization or the decriminalization, but also a recognition that there are spiritual communities that utilize these medicines and have for many generations, and continue to do so even with the affirmation of the U.S. Supreme Court. And so there is a lot of work being done around psychedelic chaplaincies, and many communities that are looking at how do they relate to this. And Rick, I think what you said is beautiful about the fact that this will be a creative process, and there won't be a psychedelic assisted therapy. There will be therapies that will be responsive to each community and each person's necessity in the delivery of care for them. I want to, Joseph, Leah, Hannah, and Rick, I want to thank each of you for participating in this conversation. for the sensitivity you've brought to the conversation, and for the passion and commitment you bring to the work that you each do. We at Reconsider, we're focused on having the important and the authentic conversations around the reemergence of these medicines, and tonight certainly qualifies for that. If any of you would like to stay abreast of Reconsider's work in nursing and with healthcare workers, as well as vets, first responders, and others, you could email us at community@reconsider.org, and we'll make sure to keep you up to date. To Dean Tony Vierwell, to Ivory Daniels, to the student participants, and the entire UPenn team supporting this learning series, to Kwasi Adusai, and to Sandy Sandberg, thank you again for the vision and the courage you have in holding these sessions. Those learning sessions, along with the stories of transformation and all of the resources gathered for each session, will continue to be available on the UPenn site. Tonight's will also be posted. For those who are looking for CE credits, I want to remind you that you will receive a link in the post-session follow-up email in the next few days. So while you can't access it in the chat, you will get that in an email over these next couple of days. There will also be, and this for you especially, Hannah, there will be a live session on April 13th, the 7th of these learning sessions, from 4 to 7 p.m. for those in the Philadelphia area at UPenn. The live event will include breakout groups, as well as the opportunity to hear directly from several people who've benefited from psychedelic medicines. For those who are out of the area, don't despair. It will be taped, and it will be sent out and broadcast afterwards, so it will be available to you as well. Finally, I would like to thank each of you out there for taking the time out of your schedules to participate, for the questions you offered, for the container you created for this discussion, not only tonight, but over the last 6 evenings, and for your interest and for your passion in the subject, and for all you will do in helping to support the reemergence intentionally and thoughtfully of these important medicines as we move forward. Thank you so much to everybody.